Hey everybody, Dr. Daniel Bodkin here from ProActive Athletic Performance. And today I want to talk to you about how we can provide objective testing for you and your patients. About me really quick. So I'm the owner of ProActive Athletic Performance in Dunwoody. I'm also the director of clinical education for CSMI, the maker of the HUMAC isokinetic system. I'm also their installer for the US. When people buy machines in the US, I install them, then I train them on how to use it. I'm also a professor or associated professor for In Tandem DPT, where I help make content for new PT programs. I've also worked for University of South Florida's athletic training online program, Nova Southeastern's hybrid DPT program as an adjunct professor and associate professor. I went to the University of South Florida for both athletic training and physical therapy. Before that, I actually shot rockets in the Army for 8 years. And with isokinetics, I worked with the NFL Combine for 6 years. All right, so what do we do here at ProActive? The main thing is we provide isokinetic and force plate testing. The second thing is if you are working with a patient and they're pretty close to me locally, I can do strength and conditioning with them after they've been discharged from you. I essentially want to finish what you started. And you'll see a couple of these little memes in here. I'm a bit of a nerd. So you got your patients all the way through prehab, post-op, normalizing movement and function, getting off the crutches, getting into those beginning exercises. And then because of the way the insurance model works, they have to then leave and then finish the job on their own. And I want to make sure that we are able to finish that job and that they're able to get all the way to their goal, whether that's just getting to be able to play with their kids again, returning to a sport, living a healthy lifestyle, whatever it is that their ultimate goal is with rehab. I want to make sure that they are able to do that. So I want to finish the job that you started with them. When you send a patient to me, what you're going to get, I'm going to send you the test reports. But I'm also going to break it down for you because unless you've been trained on how to interpret the squiggly lines and the numbers, it won't make a whole lot of sense to you. But I'm going to break down those test results for you, and I'm going to do it two ways. One, I'm going to send you the PDF of my note from my EMR, and you can even use that entire note and put that into the patient's note to the doctor, your progress note. You can even copy and paste certain elements of it into your note. I'm okay with that. But the most important part is I'm going to send you a video breakdown. So it's maybe 10 to 15 minutes usually. I'm going to go over all the tests that we do with that patient that day and give you the numbers, what's relevant, what's looking good, where the areas of impairment still are. What I'm not going to do is I'm not going to tell you what to do unless you ask for any questions later on. If you ask me, hey, how can we work on this or that? I'll then give you any insight for that. But what I'm not going to do is dictate to you what you need to do with your patients. You're all skilled rehab professionals. You're able to do that because you're also combining that with what you're seeing every day in the clinic with them, with the range of motion, with their other functional tests, right? So you're just taking what I'm providing you and you're going to put that into plan. You're going to use that to plan their next phase of rehab, determine their readiness for discharge, determine their readiness for sports. Essentially, I want you to have all the benefits of having this equipment without, dropping $70,000 on this equipment, needing the space in the clinic, and then needing to train somebody up on it. I want to make it seem as if I was working for you and this equipment was in the corner of your clinic. What you would get from me is what the same thing I want to provide you. It's just in an outsourced format. So let's talk ACLs, and really we could have the same conversation about ankle sprains, hamstring strains, total knees, slap repairs, Tommy Johns, but I'm going to be a little bit more specific to the ACL today. And the problem with the ACL is that we're still getting about 30% re-tear rate. Some studies say 20%, some studies say up to 40%. I've even seen some studies that say only half of our ACLs are even getting back to their same level of competition. So it's kind of all over the map, but about 30% is re-tearing, and that's either the same side or that uninvolved side. And even in the NFL, where we have the highest level athletes, the best equipment, the highest level of strength conditioning and rehab, they're still retailing at about 12%. It comes down to two problems, and one is time. Our insurance, it only covers the first half of rehab. You might get 30 to 40 visits if you're lucky. And you always start out 2 to 3 times a week, but then we taper to twice a week and then once a week. So we always try to ration out those visits the further out they get, just so we can cover more time with them. But ultimately, the ACL is a 9 to 12 month problem, and we're only getting insurance coverage for like 5 to 6 months of that. And at that point, we really are hoping for the best. Even if we're sending them to a strength conditioning or a personal trainer, or we write them a basic gym program, we really don't know their readiness for sport. Now, some of you might be using handheld dynamometry or Tyndec, or you have other proxies to get it, and that is fantastic. All right, getting a number is the important thing. Now, it's not as specific as what you're going to see when we do our level of testing, but at least you're getting a number for that. So I commend you if you've already implemented inline dynamometry, handheld dynamometry, or another way to kind of get a proxy for that. The other problem with time is that our return to play was pushed too early. When I graduated athletic training in 2009, the timeline for ACLs is 12 months across the board. And then we started pushing it to 9 months. Our pro athletes, college athletes were able to do it. So we started trying that with our high school athletes as well. And then we tried to, I get it. We were trying to find, the best way. Did we need to wait 9 to 12 months? So we started pushing 6 months and 5 months. And what we found as a profession is that was a little too early. So that pendulum swung a little bit too far. And now it's kind of swinging back to that 9 to 12 month return to sport. The other problem is strength testing, or the lack thereof, right? The equipment is expensive and it takes up a lot of space. Just my force plates and my isokinetic machine is about $70,000, and most places don't have the money available for that. Now, it used to be that you'd find these machines in clinics across the country. They were purchased up in the 80s and early 90s when we could get reimbursed for what we did versus our time. But then those healthcare laws changed in the 90s. But the machines themselves would last about 15 to 20 years. So as those machines started to slowly stop working and die, the clinicians got rid of them, and they didn't replace it with the newer equipment. The other problem is training. So if you have the equipment, how are you going to get that person trained up adequately? Unless you're taking my CEU course, or you learn from somebody who's already experienced on it, and they're not going to be able to be trained. And even if you got that person trained, they work for you for a couple years, but then they leave and go to another clinic across town. Now you have to train somebody else up. And the other problem is reimbursement. We used to be able to get reimbursed for putting people on individual pieces of equipment or the things we did, but now we're getting reimbursed for our time. So we're not seeing a lot of the machines being replaced when they are leaving the clinics. So we started using functional testing, hop testing, as a proxy to try to replace that isolated strength testing. And I'm a big believer in the functional test, the isolated strength test, the psychological side of it. There's a lot more that goes into it than just isokinetics, right? But we do need to get that isolated strength test as part of it. So with strength testing, this one study right here was done in 2019. They looked at patients who were cleared for return to sport at 6 months. Now, again, this is 2019, so the research was probably done prior to that. This is back in that swing where we were in that 6-month return to play timeline. So if this were being done today, they probably would have been testing them a little bit later on. And they essentially found that with strength testing and with the isolated and with the hop testing, that only 1 in 5, or 20% of the patients studied, were achieving symmetry. With hop testing, strength testing, right? And that's at 6 months. So only 1 in 5. And all of these subjects had been cleared by their physical therapist and by their physician, okay? But when we break it down, when it came to just the hop testing side of it, 68% of them were passing. But when they looked at quad strength symmetry, only 36% of the subjects had achieved symmetry there. And then for the hamstring symmetry, it was 47%. So the other thing that came out of this was they found, and other studies have replicated this, that hop testing tends to overestimate somebody's readiness for return to sport. And we're going to get into why that is in a moment. So this study came out by Lynn Snyder-Mackler's group of UDEL. It's a great great group of researchers up there. They found that just by meeting two criteria with our ACL athletes, we can reduce that re-injury rate by 84%. The first side of it was just waiting the appropriate amount of time before returning to sport. And the second side was passing a strength test. On the time side of the coin, for every month that return to sport was delayed up until 9 months, you had a 51% reduction in re-injury rate. So that means that if I returned to sport at 8 months versus 9, I was 51% more likely to re-tear. If I returned at 7 months, I was 51% more on top of that. Now, this did level out at 9 months. So just simply waiting until 9 months, you reduce that re-injury rate by a lot. On the other side of the coin was the quadriceps strength. They tested every single person in this study, and they found that of the people who didn't have quadriceps symmetry, 38% had a second injury, whether it's the same side or the opposite side. So 38% by not getting symmetry. But of those who had quad symmetry, only 5.5% retore. That's a major difference. And when you combine the quad symmetry with waiting 9 months to return to sport, that's where that 84% reduction in re-injury occurred. All right, so meeting those two. And I'm just going to let you know, and you'll see this here in a moment, I look at it way more in depth than a simple symmetrical quadriceps. Okay, so I'm looking even more deeply than what this study did. Still on the quad symmetry, they even found that for every 1% improvement in quad symmetry, you had a 3% reduction in the re-injury rate. So that's a big side of it there. All right, let's go back to the functional hop testing, okay? So this is looking at the knee contribution in a vertical versus a horizontal hop. So in a horizontal hop, which is the way that we typically test a hop test, the knee's only contributing 13% to that propulsion. The rest is coming from the hip and the ankle. So that's why a horizontal hop test can overpredict somebody's readiness for return to sport. And they're going to use the hip and the ankle to achieve that. Now, if we look at that versus a vertical hop, now it's completely different. In a vertical hop, it's about 30% across the board, right? We're at 34% for the knee. So even though we are getting some hip and ankle, now we're going to bias that knee a little bit more. And remember, this is our functional task. So we're wanting to look at the hip, the knee, the ankle together. Just doing it in a vertical is a lot more specific to what we're actually trying to test than a horizontal hop. Now, when it comes to the landing side of it, it's very different because on the landing side for a horizontal hop, the knee's picking up 65% of it. So it's a great intervention, right? So if we do this as an intervention when we hop, we're using the hip and the ankle and a little bit of the knee to accelerate ourselves and propel forward, but then we're landing it primarily with the knee. So it's a great intervention to work on overloading that knee, that quadriceps in that sagittal plane, right? So I like it for that. It's just not the best way to test as a proxy for knee strength. And this is the force plate vertical jump testing. This is a big systematic review that just came out in 2024, where they looked at a lot of different articles. And essentially what they found is that overall, people who've had an ACL, they're going to display chronic deficits in the vertical jump performance in bilateral and unilateral tasks. And it's going to have implications for return to play and targeting those interventions, but we don't have hard numbers on what's significant yet. With so much research being done and the fact that force plates are becoming more common in the smaller clinic setting, I'm sure we're going to see a lot more coming out of this over the next 5 years or so. But that's why I do like testing it, because there are things that you can pick up on with the functional force plate that you can if you're just doing hop testing in a normal setting. So now let's talk about the ACL timeline for testing. If somebody gets sent to me at 3 months, I'm limited in what I can do, but there are reasons why you might send somebody to me. So what I can do on my force plates is I'll do a single imbalance test, basically eyes open, eyes closed, and then eyes open on foam. And we're just looking at total excursion side to side. I'm also going to put them on a second force plate system I have that looks at their squat mechanics. And that's just looking at as they're squatting, either just body weight or up to about 30% of their body weight in a goblet. How are they loading? Are they shifting off to the side as they get to that deep range? Are they underutilizing their anterior chain or overutilizing their anterior chain? But the main thing that we're going to get is on our HUMAC, and this is the HUMAC machine right here. We're going to do an isometric test of the quadriceps and hamstrings to get a torque amount and a rate of torque development. Now, if you wait another month and send them to me at 4 months, now, because they've started jumping a little bit, doing a little bit of agilities, maybe some beginning landing, I can now put them on my force plates and get a bilateral counter movement jump. And the difference between a normal jump and a counter movement jump is just your hands are on your hips. So we're eliminating the contribution you get from throwing your arms in the air and getting that triple extension from that. On the machine, on the isokinetic machine, I'm still going to do that isometric test, but now I can do the standard isokinetic test. And that's concentric. This is what we learned in school. It's what the machines were capable of doing back in the 70s and 80s and early 90s. They'll push up with their quad and they'll pull back down with their hamstring. It's not the advanced test that I can do later on. Now, the reason why I would typically get an athlete in this phase is because they're a higher level athlete, or they're under a time crunch. This is your high school person going into their senior year, and they tore as a junior, and they want to make sure that they're on target for returning on time to, play for that season. Or, I have a young man, he plays high school lacrosse as a senior. He signed with a college in Alabama for lacrosse, and we'll see his test in a moment. But shortly after committing to that school, he tore his ACL. So him and his physical therapist, his physician, his family, they want to make sure that he's on track. So it doesn't have to be only the professional athlete or the higher level athlete. It's someone who's more under a time crunch as well. All right. So that's going to give us some early data that you can then use to program out that next phase of their rehab. Now, this is when most people are going to be sent to me, around 5 months, essentially before they're discharged from you, before they see their doctor for that final visit for discharge. Have them come to me, because when we can do the test, and that will help you determine, and the doctor to determine, how ready they are for that. And we'll see an example of this in a moment as well. So now on our force plates, I can do a bilateral and a unilateral counter movement jump. On our isokinetic machine, I'm still going to do that isometric test to get strength and rate of torque development, but now I can do the advanced isokinetic test. And this is a much newer form of the test. Essentially on this, we're going to be able to look at concentric and eccentric muscle functions of the quadriceps and hamstrings. It's a lot more advanced. I don't do this until 5 months with my ACLs, because before this, they just don't have the capacity in the muscle and the neurologic system to give you a meaningful test. Now, if somebody comes to me later on, I'm not going to add anything to that. On the force plates, I might have them do a drop jump or a rebound jump. And on the isokinetic machine, I'm going to repeat those same 2 tests, but I might have them do it in a fatigue state. So let's say at the 6-month test, they were really close to getting back to their numbers of what we're looking for. But then I retest them again 6 weeks later. And at this point, now I'm going to put them through a fatigue state. I might test them fresh, then put them through a really fast, like 15-minute hard workout to wear them out, and then put them right back on the machine and retest that leg, because then it lets us know what their numbers are when they're fatigued, like at the end of the quarter or the end of the half, right? Because we want to see how, what their numbers are when they're fatigued, because that can help you also determine their level of return to play. All right, so let's break down each of these really fast. First up is the isometric test. We're looking at the quadriceps and the hamstrings right at mid-range at 60 degrees. They're either going to do a 5-second torque onset and build it up. And this is for somebody who possibly had the quadriceps graft and they have a lot of graft site pain and they're not able to punch into it for rate of torque development. But if they're able to, and their pain isn't really sharp when they do it, I want them to do a rate of torque development kick into the pad. I don't do this before 12 weeks. I've done it before, but it's not going to give you that much data. So it's better just to wait until they're about 12 weeks to do this. And we're using this to identify a baseline in the early phases and then monitor their progress in the later phases. But it's also going to let us identify any yellow flag patients, and it's going to look at their readiness for returning to jogging, because it does have predicted value. If somebody's more than 30% deficient at 3 months out, they're going to have a harder time getting that symmetry at return to play, according to this study. Now, a lot of people 3 months out are going to be around 30%. It's the patients who've had the quad tendon graft with a lot of that graft site pain. Anybody who had a secondary procedure like MCL reconstruction, a medial lateral meniscus repair, the lateral articular tenodesis, a significant bone bruise, right? A significant amount of inhibition. That's going to kind of pick up on that for them. And it's not telling you a good versus bad. It's more identifying that person that we need to make sure that we're not, putting it in their head that they can get back at 6 months, right? That they're going to have a harder time getting that quadriceps back. So it's not identifying a red flag. It's more picking up a yellow flag. The second thing it can do is it can tell us how close somebody is for running. If the quadricep isn't able to get at least 47% of the body weight, I just rounded up to 50% to make it easy, they're going to have a harder time getting into running. They're either going to develop bad running mechanics, or every time they run, it's going to irritate, swell up that knee. I've seen it before where they're running too early. Now the knee gets swollen. They have a harder time getting extension back. They're going to get inhibition. That's just going to slow down that, month 3, month 4 phase, because they're going to try to run too much and they're just going to slow it down. They might be able to do their early phases. Let's say we test somebody and they're at 40% of their body weight. They can still get back to some level of running, jogging in place, maybe their first step or two on that running, jogging program. But if they try to push too much, that's where that inhibition and that cycle would set in. So just identifies that person as to know, hey, don't push it with your running out. Let's get back to that activity. Let's start to stimulate it a little bit, but let's not be overly aggressive with it yet. All right, so let's look at an isometric test. This is that high school lacrosse player I was telling you about. At this point, he was 14 weeks out. He had an ACL with a patellar tendon graft, but he also had a medial meniscus repair. So on our isometric test, really any test, all the patient's data is going to be up at the top. The top set of data is for the quadriceps. And first, what I look at is the graphs. So the right leg is going to be the blue lines, the left leg or the red lines. The higher up the lines are, the more torque they're putting out. And this is over a 5-second timeline. Now, this patient with his surgical side, that's the right side, he was able to do a rated torque development kick. But I've also had people where they can't, it's just too sharp a pain, and they kind of bring that torque on over a second to a second and a half, right? So I look at that there. He has a little bit of squiggles. I would zoom in on this if it was your patient and we were doing a report for them. I could zoom in and we can look at the amount. Little bits of squiggles with their torque steadiness is normal, but if it's a higher amplitude and it's the hertz are significantly bigger, then that's somebody who has AMI, right? And we could pick up on that, but you'd be picking up on that with your other interventions anyway, but we would just see it visually here. Next thing we look at was what is their peak torque, right? So his uninvolved side hit 111 foot-pounds. Sorry, the involved side was 111 foot-pounds and the uninvolved was 159. So at peak torque, that gives him a deficit of 30%. Which is right around what we'd expected 3 months out, right? If they're significantly more than that, that's that yellow flag patient. But then the next thing we look at is what is their torque relative to their body weight. I'm using US units of foot-pounds and pounds, and we generally want 1 foot-pound for every pound they weigh. Unless they're, a larger mass athlete, then it kind of goes down to 80 to 90%. And some females, even if they're not a larger mass, right, they'll only be around that 90%. All right, so his involved side is at 63% of his body weight. The uninvolved is 91. So that tells us we're comparing him to a healthy leg. I've had patients where that uninvolved side this early on has lost strength and it's only at 60%. So they might show that they're closer in symmetry, but they're symmetrically weak, right? So that's why I always look at that as well. The last thing when it comes to body weight is, remember, we want 50% of the body weight for a successful return to jogging program. Well, he's at 63%. So he's not going to have any problems getting into his jogging program. All right, the next thing I look at on here is what is their torque at 200 milliseconds? Because it's one thing if they build that torque up in, 1.5 seconds or so, but they don't have 1.5 seconds when they're jogging, jumping, making a change of direction, or even going down the stairs. We need to know what that torque, how much they have access to during those functional tasks. So at 200 milliseconds, now he has a 38% side-to-side deficit. But looking at his body weight, he's still hitting about 50% of his body weight instantaneously. So again, he's not going to have any problems getting back to his that next phase, that 4-month set of interventions that we typically like to do with our ACLers. Last thing is, what is their rate of torque development? So this is the torque slope. It essentially zooms in on this initial onset of torque. we cut out the bottom and the top 20% of that, because the bottom 20% is squishing into the pad, right? The top 20% is any extra they get after they've achieved that initial onset. And this reads in foot-pounds per second. I explain it to patients as miles per hour as they understand that a little bit better. But here, remember, he only had a 30% peak torque difference, but he's 49% slower. So 282 foot-pounds per second versus 556. And this is normal at this phase of rehab. He's only 3 months out. You're not going to get rate of torque development back until you've normalized that strength and the overall torque. Down here at the bottom, we have the hamstrings. Again, just looking at that graph visually. Now, if they had the hamstring graft as their donor, we would see a bigger deficit here and typically a smaller deficit in the quadriceps. So that's something we keep in mind. Looking at peak torque, he's a 37% deficit here. Compared to his body weight, he's at 39% for the involved, 62 for the uninvolved, and we want about 60% for the hamstrings here. Now, I'm also going to give you their hamstring to quadriceps ratio. It doesn't give it to you directly on this report, so I'll give you that in my report to you. We want 60 to 70% for ideal. He's at 62 and 68. So he's got a really good hamstring to quad ratio. Not all of our patients will, especially if they're focusing so much on the quadriceps initially, that hamstring might not have gotten much attention at this phase. On the other side, if they have a significant weakness in their quadriceps early on, that hamstring, if it retained a lot of its strength, we might see that it's in the 80 or 90% range, right? So we kind of use this to just look at their general muscle balance. Now, at 4 months, I can now do the standard isokinetic test. And this is using concentric only actions of the quadriceps and hamstrings. This is what we learned in school. I do 2 speeds, 60 degrees per second to look at strength, and then 240 degrees per second to look at endurance. I do this at 4 months, and it's just kind of looking at that middle phase of rehab as a way to, so it's much more dynamic than just the isometric test, because now we have the joint is going to be loaded and moved. So we have the neurologic aspects of that. We have any pain aspects of if there's any patellofemoral issues, the graft site pain, right? It's being, is not just loading, but it's loading with shortening, right? So there's that element. There's a neurologic drive that plays into this as well. So it's much more dynamic than just the isometric test. So this is a young man I worked with when I was in Nashville. He was 14 weeks out. He was an ACL with an allograft. Now, this is the standard isokinetic test. Now we have the graph on the left for the quadriceps. Everything on the right is for the hamstrings. But I look at the graph to get a visual look at it. What we see, this is the knee bent at 90 degrees. He pushes up, his torque climbs until he's usually about 60 to 70 degrees. And then as that knee continues to straighten out to 10 degrees, that torque drops down. So it's what we call an ascending descending curve. One thing I notice on here with him is that he does have a little bit of torque unsteadiness on that uninvolved side, a little bit with the involved side. If somebody has a patellofemoral issue, we would see a dip. So it'd peak up, dip down, and back up. So it's like a double hump. That's just that patella getting loaded maximally, and that pain inhibits them. But as soon as they get through that part of the range where it's less torque, it climbs back up. We have somebody with a quadriceps tendon graft. Instead of being nice and vertical onset, we might see that surgical side is a little bit more of a slant or a diagonal. Now, looking at his, you can see his lines aren't that much different. His blue, which is the involved side, is pretty close to that uninvolved side. And looking at his numbers, now we can look at it from peak torque like before. So that point versus that point, there's a 12% difference. So it's close to symmetry. We can also look at the work, and work looks at the strength over the entire range of motion. And when we look at that, he's only 9% deficient. So the problem is he's only 4 months out and he's within symmetry. That's because we now go to the body weight. He's symmetrically weak. We want it to be 100% of his body weight when he's all completed with rehab and he goes back to his sport. The surgical side is at 56%. And that's exactly where it should be at this point. But his uninvolved side is at 64%. So he's bilaterally weak. So it's the double, it's the two flat tire scenario here, okay? Now, going to his hamstrings, that's this side of the graph. So this starts with his knee extended at 10 degrees. And then he pulls down. We should see this line come up and then back down. His is a little bit flat on both, and he's close to symmetry. So we see that visually on the graph, and at peak torque, he's only 4% stronger on the surgical side and is exactly the same strength for the entire range of motion. But again, symmetrically weak. We want 60% of the body weight. He's at 35 and 36. The problem with this athlete is that the doctor, because he was symmetrically weak here, and then I retested him with the advanced isokinetic test. He got stronger, but again, he was symmetrically weak. So his doctor let him go back to soccer at 5 months out, and guess who had a meniscus tear like 2 months later? So like I said, I'm not just looking at symmetry, I'm looking at symmetry, how it relates to the body weight. In a moment, we're going to look at the neurologic balance with the advanced test. So I look very in depth with a lot of these different things. Had good strength ratios. Now, when I do the fast speed, this is actually my test. The only thing we get out of the fast speed is the fatigability of the muscle, or the fatigue index. Now, you can look at it on the graph. You can see where my right leg started on its first rep and where I ended on that rep. And same thing on my left leg, where I started and where I ended. It's doing 15 repetitions, and it's taking your first 3 repetitions average compared to the last 3 repetition average and what percent of strength reduction we had. So my quads, they both fatigued at 38%. That's normal. My hamstrings were around 30-ish%. And there's no hard cutoff on this. You're just looking at the other limb as the comparison. All right, this is where most of your patients are going to be sent to me, is around at least 5 months out, right as they're getting ready for discharge. So 5 or 6 months, and then we retest later on when it comes to return to sport, or if we're checking their progress. So now we're doing concentric and eccentric contractions of the quad and hamstrings, and I'm only doing 1 speed. I don't do this until they're at least 5 months out, because there's just so much going on neurologically with strength, the eccentric side, that you're not going to get a very significant, reliable test until they're at least 5 months out. And some with our quad tendon graphs, 6 months out. And this is looking at their progress and measuring their status in the early to late phases of rehab, and it's looking at their readiness for return to play. So this is a young lady I'm working with right now. She's going to college. She's a lacrosse player, and she's home in Atlanta for the summer. She's 6 months out. She had the quad tendon graft for her ACL, but she also had the lateral extra-articular tenodesis, or the LET. So on the advanced test, the first page is going to be all quadriceps. The left side is the concentric quadricep. The right side is the eccentric quadriceps. Let's start with the concentric first. So you can visually see that she's weaker just by looking at the torque. One thing I noticed here, because she had the quad tendon graft, she's a little bit less vertical on that onset from 90 degrees to about 60 degrees. That's just the nature of quad tendon grafts, right? They don't like being loaded in that deeper range. Looking at her the deficit at peak torque, she's 53% weaker and 52 over the entire range of motion. And relative to her body weight, we want 100% most of the time, unless the person is some females, they're going to top out at 90%. And then you also have some athletes who are just higher mass. Think of your offensive, defensive linemen, your centers in basketball. They're going to have a harder time getting 100%. So we allow them 90% and bilateral difference there. All right, looking eccentrically, what you should notice, other than the fact that she's weaker, is that we have these squiggles. So this is torque unsteadiness. It's inhibition, essentially. That muscle hasn't been loaded deep enough through the range of motion. She's been loading it effectively to about 45 to 50 degrees, but she really hasn't loaded that quadriceps through that deeper range, and especially isolating it. And she's also the quad tendon graft. So as that muscle is stretched, as it knee flexes, again, she's pushing up, and that machine is forcing her knee down through flexion. So that's going to put a lot of load through that graft harvest site and the quadriceps as she's nearing full flexion. And that it just doesn't like the load, and that pain she's getting is giving an inhibitory signal to the quadriceps. So we see the bilateral deficit. It mirrors the concentric 52 and 54%. And looking at percentage of body weight, we want 130% or 115%. Her uninvolved is 110, so it's got a little ways to go, but the uninvolved is at 52%. So about a little bit, under maybe a quarter, a third of the way there, right? So she's getting there. That will improve as she just continues to load that quadriceps through the deep range, because what we'll see as she does that is that the muscle is able to continue to generate torque. And even if we followed this initial lineup here, it would come up and it would hit it right around there. So we would see that naturally as she's loading deeper through the range of motion. All right, next up, we have the eccentric to concentric ratio, and this is looking at the neurologic balance. You should be 30% stronger eccentrically than you are concentrically. And so what it's reading is because it's an eccentric to concentric, the ideal is 130%. Well, this athlete, her involved side is 125 and the uninvolved is 132. So even with this inhibition, she's getting eccentrically, she's still stronger than she is concentrically. So that's good. Next, we go to the hamstrings. Concentrically on the left side, you can see her lines are pretty much just below, or actually cover directly even strength through part of the range of motion of the uninvolved side. So at peak torque, she's 15% weaker concentrically. And if we looked at the entire range of motion, she's only 7% weaker. Looking at the percentage of body weight, for the involved side, she's hitting 41%, 48% for the uninvolved, and we want 60%. And again, for females and some females and some of the larger mass athletes, it's more like 50 to 55%. Eccentrically, so not only does she have a slight weakness compared to the other side, what we should see is what these blue lines do. We should see the torque get stronger and stronger as they're loading. So essentially, this is 90 degrees on this side with the knee bent. They're pulling down and it's forcing their tibia up through extension. And we should see that as the knee extends, the torque increases all the way to 10 degrees. But for her on her surgical side, it stays flat. Now, if somebody's had hamstring issues in the past or they have the hamstring graft, what we'll see is in their last 30 degrees or so, instead of not even staying flat, it'll dive down, it'll curve down. That means that as they're nearing end range, that muscle just gives out. And now they're at risk of getting a hamstring strain the first time they get out on the field or court and they take off, right? So she's not having that, but we would like to see that these lines continue to gain torque as she hits near full extension. So at peak torque, she's a 20% deficiency, 8% if we're looking at the entire range of motion. And relative to the body weight, we want about 80%, 70% for some people. She's at 50 and 62. These are naturally going to come up as she gets into some of those advanced exercises like RDLs, deadlifts, barbell hip thrusters, things like that. Nordic hamstring. So we'll see those, the hamstring numbers go up to what we want. The biggest issue with her right now is just this quadricep still, right? Okay. For her hamstrings, we have the neurologic balance or the eccentric to concentric ratio. Both of her eccentrics are a little bit weak relative to where the concentric is, but that'll come up. And then I would also give you for them, I don't have it on here, is what is the hamstring to quad ratio? I can do the standard way where we take the concentric hamstring divided by the concentric quadriceps. And that should be a 60 to 70% ratio. But we also have what's called the functional ratio. And if you think about it, your quadriceps is the motor accelerating your tibia and foot forward, and your hamstring are the brakes because they have to decelerate that. Well, we want that to be a 1-to-1 ratio. So I would figure that up for you as well. All right, so the question that your patients are going to ask you is, well, how much does this cost to come here? For me, my single visit charge is $250. Now, if somebody were to buy a test package for me, let's say they test out at 5 months, 7 months, 9 months, right? If they're going to do multiple tests, I give them a discounted rate. I don't make them buy a package. I hate selling packages because not everybody needs a certain number. But I'll give them a discount of $200 a session. But that's the discount that I'm going to give your patients automatically, right? So I'm already going to knock off $50 from the total amount of their test. Now, if you have somebody that just absolutely cannot pay that amount, I want them to get a hold of me anyway. I would rather have them pay me a lesser amount and trade that in for, Google reviews, social media posts. I want to make sure that every one of your ACL athletes or even your non-ACL athletes, I want them to get a test. I do not want them to be one of those stats of a re-tear because of a monetary issue, right? So I still want them to come in, we'll work out a price that they are able to pay. Now, if somebody is in the Dunwoody area and after they're discharged from you and we do their test and we see what their status is and they decide they want to do strength and conditioning with me, for them, I charge $175 a session and it's about 10-ish sessions. Now, I'm not going to make them buy 10 sessions, But so again, I call it a package, but I'm not actually making them buy a package up front. I'm going to charge them per visit that they come in, but I'm going to give them that rate as if it was a package. Now, the other thing is that I do provide a super bill, right? They're going to get a super bill that they can submit to their insurance for out-of-network benefits, and patients can pay with HSA, FSA, or credit card. So even though we call ourselves a cash practice, it's not a cash practice, right? So again, I want to make sure everybody has access to testing, and there are multiple ways that we are able to make this happen for them. Just to recap for you, nationally, our ACL re-tear rate remains pretty high. Even though surgeries have improved, rehab has improved, right? So it's still really high. Our ACL athletes should have access to a testing battery of objective tests, isolated muscle and functional tests. The testing that you're doing with them in the clinic is part of that as well. The psychological readiness test that we give, some of the forms, that's part of it as well. And because clinics don't have access to it within their facility, now we have access to that through us, just outsourcing your testing facilities. So we can provide those testing, those isolated and functional testing to get the objective data for your athletes to not only look at their return to sport, but also to monitor their progress through rehab. I have some references here for you. Now, I do teach a full CEU course on this, and my reference list on that is about 98, I believe, at this point. So if any of you want to discuss any more about isokinetics or testing or any of it, I would love to have that conversation with you. If you have any questions directly for me, whether it relates to testing in general or your athletes, I want to make sure that we can do that, okay? If any of you have an athlete and you just want to see how it works, right? I always provide the very first test for a clinic for free. So I want you to be able to see the value in the data that you're getting from us. I also invite you to come in with that athlete to get the test so you can see it actually happening in person, or if any of you want to come in to try out any of the equipment yourselves, right? I want to establish this relationship with you as though I was working for you in the clinic with this equipment. So thank you very much for watching all the way to the end. And please get a hold of me through the email or through my cell phone. You can go ahead and give me a call or a text that way as well. Thank you very much. Have a great day.